think you guys set me up really well, and pretty much a lot of topics were discussed. And hopefully, first of all, great pleasure and honor to be invited here, be amongst these amazing luminaries. I really hope I can do justice to you and deserve a spot in this place. And so, what I'd like to talk about is been working this for years. How circumferential MIS surgery can reduce PJK and hardware failure and present our data we have. In terms of disclosures, there is some bias here. I do have royalties for some of the equipment you will be seeing. So take that with a pinch of salt. First, just to qualify what severe adult is, right? A lot of people may not call this severe, but this is adult deformity. You're not dealing with neuromuscular, congenital, infantile. This is adult deformity. And I think it's fair to say a COP greater than 50 or any Schwab plus modifiers also included in there would pretty much, most of us would consider at least in the realm of severe adult deformity. But I really want to get past this mild and moderate that seems to be talked about all the time. These are all the patients we're talking about. These are the patients we treat every day and literally over the past 17 years. So hopefully we can come to a point where we can discuss basic tenets, right? I think this is really important. The indications for me are massive, and patient profile is a huge part of it, and that's 90% of everything you're going to see. This talk cannot access that and will not discuss it, but I think it's a really important part of what you're seeing here. The next is this. The MIS axis, to me, is tissue sparing and anatomy focused. It's a segment to segment anatomic profile that matters. We'll talk about that. Every segment is individually studied, and we'll talk about that. And then the execution, truly, I put a surgeon profile because we each like to do what we do, and that's fine, as long as we execute what we are going to do to take us where we want to get. So it's not about a technique, and that's what I want to make really clear. It's about really a global protocol of addressing the issue. Patient profile, I think we all know. None of us hopefully would operate on someone who doesn't deserve it. The indications do not change. I've categorically said that. MIS surgery should not change indications. That patient still needs surgery. Then you decide to do it, MIS. And if someone does not have back pain, I'm not doing deformity surgery. Then they will get one, at least with me. All these patients have been treated circumferentially MIS without a single osteotomy, not one, not even a facet resection. So let's talk about how we get around to doing that through our protocol. In fact, every single patient who's not fused today is treated this way. If they are fused, it depends how many still open discs we have to access, and none of them get a single posterior column osteotomy. We presented this protocol before. The crux, the other thing I wanted to get out is, I don't stage everybody. It's 4 or more interbody levels, elderly patients greater than 70 or pretty comorbid, or if the first stage for any reason takes longer than 4 hours. And we'll talk about the advantage of staging. So 2 and 3 and simple levels, I'm not staging. I want to get that out of there's some confusion. We're staging everybody. No. The first stage is all the laterals, all done in a single position. We get them up, walking, moving, get standing x-rays. And second stage would be the percutaneous reduction, translation. We'll talk about that. There's a whole method to that. The key, again, is this, accessing anatomical corridors, right? It's not about a tube. But I think the best definition to me is accessing anatomical corridors with minimal soft tissue disruption, devascularization, or denervation. I've said this many times, ACDF is the greatest minimally invasive surgery we do every single day. So it's that corridor that exists that determines the access. So we got to study that corridor, right? If it's there or not. So everyone gets an x-ray, and in the x-ray, the carb is selected, right? The whole carb is included. But like I talked before, the UIV for me is the first normal, neutral, parallel, vertebral body on x-ray and MRI. So in this case, it would be probably T11, where I'll cross that and not stop cross there. The T11 or T12, either would be fine in this particular patient in terms of my UIV, right? So at least that selection is done. All the parameters are calculated. We know where we want to go, and we sort of have an idea of what we are trying to correct. So we get, but more importantly, treat the patient, not the deformity. If someone's got single level radiculopathy at L4, even in a deformity, I'll probably do a TLIF. They don't need a whole correction. But the other part we talked about, the age-appropriate global sagittal and coronal balance. And we talk about how that comes about. And key is, again, talked about the 4-to-1 lordosis. But I think the most important part is we cannot compromise principles because we're not comfortable doing it MIS, but we say we're doing it MIS. I think Jan's brought that up. We are seeing, unfortunately, a whole sort of unfortunately crazy stuff going on of stack surgeries and independent surgeries and really not looking at the deformity. And that is quite sad and truly deplorable. And I don't think we should be doing that. Now, global alignment to me has been simple, head over hips. And this is pure ligamentotaxis. I'm going to say this, I'm going to repeat this again. You actually cannot overcorrect a patient because you have not done an osteotomy. You're achieving pure ligamentotaxis to get the correction. So hopefully we can go back to talk about that in a minute, how that comes about. We look at all this on the x-rays, but I think the most important part of what you're talking about is rotation. What's that rotation at the apex? But when you're doing a lateral, that's going to come into tremendous bearing so that you don't go off axis and you're able to position the interbody in a proper way. Obviously, spondylolisthesis, lateral listhesis. And secondly, you cannot see an pedicle on the x-ray. You're going to have a hard time on table trying to do that. So think about that. It's osteoporotic. Think about it. MRI is critical for me, not for the things we look at. Yes, we look at stenosis and look at all the other things we do. But for me, it really is the feasibility segment by segment. I'll talk about what that means. And we're looking at the natural areolar plane so that we can access it. So let's take this patient. You have the deformity, you have the stenosis, and you're looking at all these things, right? You take all that into account, but none of that changes what I'm doing. The key that changes is the vascular bifurcation. If the vessel is already bifurcated, it's an ALIF in the lateral position for me. If it's not bifurcated and I got space between the servus and the aorta, it's a lateral approach for me in the lateral position. So it's very simple. The Mickey Mouse services, high riding crest, none of them make a difference anymore. It's either an ALIF in the lateral position or it's a lateral approach, lateral position, all done in the lateral position. We can explain that. Here's 3-4, axis between aorta and servus, right? You come down to 4-5, it's already split. It's a Mickey Mouse servus. The iliac vein is coming, spreading across. That would be an ALIF for me at 4-5 in the lateral position. It's already split. And the iliac crest will be high in this patient. And here's 5-1, similarly split. So this patient will get a 2-level ALIF in the lateral position instead of getting a 5-1 ALIF and laterals elsewhere. So here's another patient where 5-1 I could go lateral. So really it's the anatomy of the vasculature that determines the access segment by segment at each level. And that determines what our true corridor is in a minimally invasive way. I've always said if you got ACDF is the best procedure we do, and this is akin to a lumbar ACDF today if you go in this fashion in an oblique approach and get down there. We all know thoracic abdominal approach, also have done it, and all we've done is taken it and made it 3 small incisions. But the key is not the muscles. The muscles are not cut. They're split. You can drop a tube down. You can get to the spine in question without ripping open all the musculature just to get the levels we wanted to get to before. Basically, that's all we've done. There's nothing fancy. We've all done open thoracic abdominal approaches, but learn the techniques to do it through a tube. CT is extremely important because you're going to miss fuse levels. There will be levels that will be fused in that deformity. And the CT helps a lot. Like the 2, gas is great because you know the vacuum phenomenon, it moves very well. You'll be able to mobilize the disc and get lordosis. But watch for the fusion that's going to burn you. For this patient, look at this patient in the middle. You can see 2, 3, and 4, 5 are fused. And the MRI is very easy to miss those things. But I still got disc above and below to work at to get my correction. Look at this patient, 3/4 is completely fused, facets fused. You cannot see that on MRI. So bending films are useless. All I need to know is that segment fused? Back to segment. If that segment's fused, I cannot do a lateral there. I'm going up or down to get my correction. And that's what I need to know. I don't need an osteotomy. We still can get correction at the other levels. Bone density critical. They all pre-treated, T-score less than -3. Now we're going to Hounsfield units. Put them on teriparatide only to make sure they're on it. Then we'll do surgery. I don't wait any duration of time. But if it's between -2 and -3, surgery and teriparatide, this has singularly changed the results. We just presented SRS 11-year results on that. and how the Hounsfield units definitely increase after doing that. We do not need an ACR in every single patient. It's only for two indications I do an ACR. Fuse 4-to-1, 3-4 bag. Fuse 3-to-1, 2-3 bag. That's a great alternative to a PSL. So certainly a great alternative, great approach. Here's a patient, similar fashion, treated that way, all MIS. Y stage, you got two short surgeries or one long one of 3 hours each. You mobilize them same day. They get up and walk. They don't go to the ICU. You know you got indirect reduction or ambulation. And then you can truly fine-tune that coronal sagittal balance with an intervening X-ray, which I'll show you in a minute. And that's not talked about at all. This is a huge factor in the correction of major deformity, rod contouring, percutaneous passage, reduction, derotation, translation. Nobody seems to talk about it. You're not just throwing some screws and lining a rod up. The iliac screw is a percutaneous inline MIS iliac screw. It's low down. You can go right below on that crest. It's 1 finger breadth lateral to your S2 AI entry point. By the way, anyone wants to feel it, it's right there. You can go directly in the iliac crest. It's the best pedicle screw you'll ever put in. No fluoro, no nav. You just feel it like a pedicle screw and drop it down. That's what we do routinely. It lines up and it works very well in terms of putting iliac screws. In terms of the rods, contouring and staging, this is what we learned. If it's a degenerative scoliosis, it corrects with the lateral. And you just put your screws and your rod and get your lordosis. But it's an idiopathic scoliosis, it is not. It never corrects. It's the rod and screws and the derotation that gets you your correction. So I think it's important to determine what are we talking about when we're using these techniques. An idiopathic scoliosis is really important to derotate and translate, and thereby you need to know those techniques to get there. There's another patient, and we can go, it's the same protocol. The best part about this protocol applies every single deformity. It doesn't matter where, how big, how small it is. It stacks up very well. There's another patient with sagittal imbalance, and you can see the correction pre-op, intervening stage, and post-second stage. So we looked at how much do we get from the first stage and the second stage. It's fascinating. The first stage gives us 95% of our lumbar lordosis. This is a complete paradigm shift from what we've been told, that laterals do not give sagittal correction. We're not seeing that. We are seeing great sagittal correction with the laterals consistently, with an ALIF at 5.1 and laterals at the other levels. Whereas coronal correction is what happens with the rod derotation, translation, and reduction. That's where the coronal so you need techniques for rods, derotation to get that coronal correction, which is why I believe severe deformity is not being done, because you need to understand this concept to get this correction instead of just putting rods. Also, we can do selective thoracolumbar fusion and save this thoracic curve. Here's this patient, the double curve, as you can call it. And what you do at staging is realize you got your correction. There's no persistent thoracic kyphosis. Patients globally and sagittally imbalanced. The thoracic curve does not hurt. They do not need a T2 to pelvis. And we got series of these on. Here's another patient. We can consistently show the same pattern. Here's thoracolumbar kyphosis corrected without a single osteotomy with this protocol we talked about, going lateral and lining them up, screws and rods. There's another physician's wife, same thing, thoracic curve left alone, realigned, corrected. All these people doing extremely well. This is a 12-year follow-up on something started way back there. Pure thoracolumbar, left the rod long enough. She never needed it, came to me now for cervical spine, by the way. There's another patient, 12-year follow-up, 08. See that action at the bottom? Please do not do it. I do not use it at 5.1 anymore, ever. But in this patient, it did well. Again, same thing, did very well. And the advantages are you get indirect reduction, you get an intervening X-ray, really see what you need to do, and you convince yourself you don't need a long construct. And so running to do a T2 to pelvis, and without a question, 2 short surgeries, an 80-year-old of 3 to 4 hours seems better than 1 long. I always quote this paper, single level lumbar fusion, increased risk of reoperation 2.1, surgical site 9 times, sepsis 4 times. And we can go on and on. This is a single level lumbar fusion. And there's a lot of data on laparoscopic literature and surgical literature talking about operative time as an independent factor of complications. We need to look at that. Data we published longitudinally over the years, I think many have seen it, multiple papers from ISSG, for too many to even count, to talk about MIS. This paper I like looking at prospectively the 1-year data after circumferential compared to open. And we're seeing at least it's equal, if not better, compared to open surgery at 1 year. The 2-year data should be out soon, very soon, from our prospective ISST database. So hopefully we can show even multi-center, we can get there. But this is the paper I wanted to come to, of PJK and PJF with this whole protocol, with a long-term 13-year follow-up, 184 patients, 4 or more levels. The PJK was 11% with the PJF of 5.4. 10 patients added. You can see all the UIVs there scattered across. Did not make a difference what level the UIV was. Secondly, the delta SVA, or the magnitude of correction, did not make a difference to the PJK or PJF rates. Again, we have all the UIVs where they are. It's all plotted out there, did not make a difference. And what we saw, though, was this gradual decompensation over the years. This is my patient, 2009, 17, 20. You can see how it gradually decompensates and ultimately needed a PSO. Then this paper just got published. It's online already. Of severe adult deformity, again, without single osteotomy, 13 years out, just talking of the same protocol. We talked about 136 patients with all the criteria we talked about. The functional outcomes are statistically significant across the board to last follow-up. Same with radiological criteria, statistically corrected across the same protocol we talked about. These are complications, intra and oval segmental artery and retrocapsular hematoma. Luckily got away with clipping that segmental artery. And then neurological injury. We've talked about other complications there. And then severe deformity in terms of all the complications out there. But what I point your attention to is hardware failure, 2.2%. And we're going to talk a little bit about that. These are all the patients. This is a 5.5 millimeter titanium rod. These are the hardware failures, of which only 2.2 was symptomatic, 3.8 was a total. Interesting hardware failure, which I think Chris talked about it, is 5-1 fuses, but the set screw is the one that gets loose. It's fascinating failure that happens more than anything else. At the end of the day, though, the only answer I have for this is this. It's a harmonious physiological restoration with ligamentotaxis. There's good anterior column support, osteoporosis pre-treated, good indications. Staging allows it to tune. I do not need a single osteotomy, and you cannot overcorrect. Age-appropriate balance, not a single in situ bend in the rod, and no too much metal syndrome. These are 2 titanium alloy 5.5 rods. So I think it's an appropriate way to do it in severe ASD. I think the conversation go beyond it. It certainly can be done in severe. We've been doing it for 17 years now. Anyone wants to see it, please come to our fellowship. Happily show it to you. Thank you.
Neel, outstanding. Thank you. Great to see you. Sorry you couldn't make it. I know you tried to fly up here, and we had 1,300, I think, canceled flights. But you were evocative and insightful as ever. Here's some questions. So for me, technically, one of the hardest things to accomplish in these degenerative scoliosis in the lumbar spine is a lateral listhesis, a sideward slippage of the spine. Do you think that with MIS, you have some better tricks and tips through lateral or oblique or whatever approaches to kind of get the spine stacked onto itself again?
Great question, Jens. I think everyone worries about it. But honestly, as you work the disc space, release it and start distracting it, it starts realigning itself in a lateral approach. It's almost self-intuitive. Because we are lateral right there, I usually go on the left side always, whether it's convex or concave. But I think it's all about working the disc. You have to patiently work it, dilate it, distract it. I liken it to a bunch of blocks in a sock. If you straighten the sock out, the blocks line up. That's exactly, I think, we're doing as we ligamentotactically reduce the spine to its natural alignment, if you will.
Great. And then a big ongoing question is that of sacroiliac joint fusions. So we saw big presentations this morning. Sadly, Dave Polly has fallen ill, and we wish him our best, but we had great presentations by Dr. Roland Kent, who filled in very ably. The question has been, should we fuse SI joints routinely in these patients? Is it enough to just put a big iliac screw in or a S2AI screw and then stabilize to the spine? Or are patients better off in the long run when we fuse the SI joint properly?
Again, great question, Jens. All I can tell you is our experience right now. It's about 17 years. I must say I'm not seeing SI joint problems in all these deformities we've done. All of them have had iliac screws. I did do S2 AI screws, maybe about 30, 40 cases. And we talked about the skiving of the medial wall of the ilium. That is real. And you can get a virtual navigation image also creating a problem. So yes, so I would much rather, I don't know. I would not say we should routinely fuse it. I would rather wait till they get symptomatic and fuse them when needed.
Okay, that's fair enough. Final thing again is one more time. I just struggle with that, but your x-rays look very compelling. The upper level of an instrumentation and deformity, how does that relate to being in a neutral part of the spine versus the kyphotic apex of a gibbous of a spine? So how much do you want to kind of stay below the gibbous? And isn't it easier sometimes to just go above, especially in osteoporotic patients?
Well, as usual, phenomenal question. Never go to the kyphosis. I do not stop there. Always cover the cob. And that's how we calculate that, right? And invariably, most of thoracolumbar deformities that I'm able to stop at T11, T10, T12. Obviously, you got a massive thoracolumbar kyphosis, you go above it. So yes, without a question, calculate that. Do not stop at a kyphosis. Do not stop halfway in a cob, and do not stop on a grossly rotated vertebra, which Professor Debussy talked, and he's dead on. It has to be neutral if you're stopping at it.
I have an add-on question. You mentioned the Debussy word. Do you attempt a rotational deformity correction in your patients, especially in the thoracic spine, given your MIS techniques?
Yes. But the only difference is we do a spine to rod correction rotation rather than a rod to spine rotation. It's the exact opposite. The spine comes to the rod. So it's just a different way of derotating it. That's all. You have to derotate.
Loved it. Dr. Shaffrey just came back. You'd have to come to a microphone. Any suggestions about Neel? I mean, he does such a great, beautiful job. He has long-term follow-up. I feel I'm doing something wrong. I'm missing something, but give us some words of wisdom of what the magic is outside of smart water. He denies that it's smart water.
Well, as I said, I think that that the population in general, the Southern California population, is a little more amenable to those techniques. You go to Mississippi or you go to Durham, and suddenly it's a little bit of a different world. But I think that I really do think that Neel has done things the appropriate way, and I think if you look through it, I think he would even admit it's been a little bit of trial and error, of different things he's tried to move and advance the minimally invasive techniques. And I think hopefully it occurred the day after I retire, but I think that eventually 80 or 90% of things can be treated minimally invasively. I still think like that Ms-Depth diagram, I think really complex revision, solidly fused, poorly aligned stuff still isn't an MIS operation. But I think most virgin things you can effectively do through MIS, and I think the technology is improving. So I think that Neel has done a great job of advancing that field. I think he's done it in a very responsible way. And I think he also very responsibly has been people when he finds something that doesn't work, that he doesn't, he says, look at, I'll give you an example. I think that he was somebody that was, for a period of time, enthusiastic about, axial lift through the sacrum up into there, and he just saw that the results weren't as good as he wanted them to be, and very responsibly reported that and moved on and did that. I think that's what, if everybody, if each of us does that, I think that, the world of spine continues to improve. So I congratulate Neel for all of the great work that he's doing, and I find it very compelling.
Thank you, Chris.
All right. Thank you, Neel. Thank you, Chris, for your great commentary.
Thank you.
If you can, please.